Across the province, Ontario residents make more than 5.25 million visits to the ER every year. Once they're through the doors, every minute counts. That's why the Ministry of Health and Long-Term Care is investing in shorter ER wait times with a program called P4R.
The P4R program is actually a program that's sponsored by the Ministry of Health and Long-Term Care, and we work with organizations within the South West LHIN in order to enable them to develop strategies and initiatives to target improved wait times and an improved patient experience within emergency departments. And the program really focuses on organizations that see greater than 30,000 emergency department visits per year.
The P4R program was introduced 4 years ago, and so far more than 70 of Ontario's high-volume hospitals have participated. Here in the South West LHIN, 3 hospital organizations are taking part: Grey Bruce Health Services in Owen Sound, both sites of the London Health Sciences Centre in London, and St.Thomas Elgin General Hospital in St. Thomas. The money participating hospitals receive is to be used to fund projects that decrease overall ER wait times and lower the time patients wait for an assessment. That could mean projects like expanding staffing or renovating their emergency room to improve patient flow.
Each of the organizations are funded a little bit of money, and it acts as seed funding in order to enable organizations to try different initiatives and strategies, little innovations that may or may not work, not part of operational business, but could become part of the regular way of doing things if these initiatives are successful in reducing wait times.
At St. Thomas Elgin General, the program meant they could reconfigure the emergency department and create a rapid assessment zone.
It's kind of our lower acuity, fast-track area to two-stream our patients. So we have part of the department, it's the acute department for our sicker, higher acuity patients that need some more nursing care, physician care, and then we have the RAS to get that volume of patients that need to kind of come in, see a doctor, go home again.
With the admission process, we looked at all the stakeholders in that process, from housekeeping to nursing to physicians to the ward clerk to the patient flow manager. And we had a meeting and we looked at all the data associated with those different departments, and we did a swim lane diagram, and everyone that has something to do with that process has a specific part in getting that patient from the emergency department up to a bed in 9 hours or less.
At LHSC, the department has launched a process called See and Treat.
See and Treat it's a process. It's not a place or a spot, a physical plant in the department. It's a concept or philosophy wherein we bring the patients to the physician as soon as we can. The physician assesses them, and then we do their treatment. And then we kind of move them to a different geographical area where they wait for the results. When those results are back, we move the patients back into the care spots. The physicians reassess them, and they decide whether they need to go on and be seen by another doctor or whether they're able to go home. So it's just kind of, I guess a short, snappier version of how you move through the emergency department.
Grey Bruce Health Services also made changes to the way patients are seen.
I made a lot of changes within the ER itself in terms of locating equipment closer to where the nurses and the physicians need them, changing where we see our patients to provide more spaces, and changing the way we do our work so that patients, people coming through into the ER don't have to wait as long to see a physician and don't spend as much time in the ER as they did before.
An ER wait time is measured by when a patient is registered or triaged and ends when a patient is discharged from the ER or is admitted to a hospital bed. The program measures length of stay for both admitted and non-admitted patients with a target of a 5 to 10% performance improvement over the previous year. Getting those patients the right care in the right place doesn't only affect the emergency department, but the impacts are felt across the entire hospital.
One of the things that we actually focus on is that the emergency department is a snapshot of how the rest of the hospital is functioning. When the rest of the hospital systems fall apart in the units, or we get, overflow of patients and things like that, it really bottlenecks back down to the emergency department. So we're trying to break down those silos within the hospital, that every unit is individual and every unit separate, because everybody has to work together, whether you're, the units upstairs or housekeeping, as Mike had said, or anybody that's involved with the patient. Everybody, we're trying to recognize that everybody's here to support the patient, and when the emergency department is not functioning well, it might not necessarily be an emergency department problem. It could be somewhere else within the building that we have to look at.
Wait time data is collected monthly, and so far improvements can be seen in many areas.
Different organizations that are participating in this program this year have had and experienced different successes in different areas. St. Thomas overall has improved their performance since just this summer, with getting patients that are going to be admitted to their beds by over 2 hours. So that's a significant achievement from a patient perspective, in flowing through the emergency department, meeting all of the steps along the way, and then actually getting to a bed. Grey Bruce Health Services has improved to date their wait times by over 5%. So that's looking at both non-admitted and admitted patients. And London Health Sciences has, while they did experience some initial improvements, has continued to struggle based on bed capacity and occupancy issues.
What it means for patients is they get their health concern addressed sooner. But a better patient flow also impacts the staff, making the Pay for Results program easy to embrace.
We're starting to see positive effects on the staff. Like I said, they're starting to ask if we're going to be running the See and Treat today. The triage nurses are they're seeing and they're feeling a significant difference in the waiting room. By moving patients into the internal waiting room faster, they're responsible for fewer patients in the waiting rooms. That's allowing them the time to do the reassessments that they need to do out there. Staff within the pod, they're also, they're feeling that flow, they're feeling the turnover. The physicians are saying, yeah, gee, this is working well. There's always bugs in the system, and some days the flow works better than others, but definitely the numbers are talking. We're seeing about 35 to 45% of our total daily volumes through approximately 7 chairs to 3 stretchers. So it's pretty significant.
A better patient flow through the hospital organization means patients who need a bed can get one in the right place at the right time. Solutions generated by the Pay for Results program can also be applied to problems in other parts of the hospital, like struggles with alternate level of care cases.
Struggles that we face on a daily basis are patients that come into our hospital who require our acute medical services, require treatment, and then they no longer need the services of the acute hospital. They may need long-term care, rehab, or other sorts of services, but unfortunately there's nowhere in the community right now for them to go. So they end up staying in the hospital, staying in a hospital bed, and then when we have patients that come through the emergency department that are in need of a bed, in need of our acute medical services, there isn't a place for them to go. So we've really looked at some of our processes and how do we get people discharged from the hospital as well, looking at community services, looking at rehab, complex care beds, and really determining what's the safest place for the patient to be, so that we can actually free up our beds for new admissions that are coming through the emergency department, as well as patients coming in for surgeries that need to stay post-operatively.
And sometimes you have to search outside of the ED and target improvement strategies such as Home First and other initiatives, and build those into the planning so that you can improve patient flow throughout the organization rather than just focusing on the ED. And while the end outcomes for the Pay for Results program really are essentially focused on within ED wait times, working on strategies that include the entire patient flow through the organization will help support improvements to the ED wait times overall.
Now that the program has been in place for several years, organizations are focused on sustaining the gains and sharing positive outcomes with other emergency departments.
There are also discussions ongoing about, how do we share some of the lessons learned, some of the significant achievements, and some of the improvement strategies that are working within these organizations? How do we share this knowledge with other emergency departments that may be smaller and not able to participate in this program? And so there's a lot of work as a LHIN talking about a strategy for developing an ED network, and that is an opportunity where I see some of the improvement strategies and some of the lessons learned, some of the key messages being able to be shared and discussed at those tables.
The changes that we've made to the ER, those will continue. The idea of seeing people in a expedited fashion through our minor emergency area and treating them as quickly as possible, those will continue regardless. I think we understand that they're good patient care practices, and these are things that we should be doing. And I don't think that the staff would stop finding more ideas or better ideas for things to change. So I think we would just continue on in the same fashion. If anything, the learning has been that we can change our environment, we can change our practices, and ideas can come to fruition. So I think that would help the staff to continue to think, I have an idea about something, what can we do?